We are live in YouTube. We are going live, broadcasting in 5, 4, 3, 2. We are live.
I want to thank everybody for joining us for our 4th installment of the Miami Pediatric Neurosurgery Zoomposium. Today, we're going to be discussing craniosynostosis, the insights into open and endoscopic craniosynostosis management. Heather, would you do the honors of introducing?
Yes, so I'm very thrilled today to introduce Dr. Mark Proctor. I think most of you know him, but for those who don't, he's the neurosurgeon in chief at Boston Children's Hospital and a professor at Harvard Medical School. I've been fortunate to have him as a phenomenal mentor, and he has incredible insights into both endoscopic and open correction of craniosynostosis, doing a tremendous number of these cases, including several this morning. With that, we'll get started. I hope all of you will think of questions as the talk goes along. You can use the Q&A function to ask your questions, and then we'll ask them at the end. Thank you again.
Great, thanks Heather and Toba. Pleasure to be here. I'm just going to start to share my screen. All right, are you able to see the screen?
Yes, it's perfect, doctor.
Great, great, thanks. Really an honor to be doing this. Nice to have an opportunity to put on a tie, which happens once every few months these days. So Heather and Toba asked me to talk about cranial synostosis and especially the insights into endoscopic and open correction So hopefully I'll be able to share in the next hour or so a little bit about the basics of synostosis and some of the treatment options. And my plan is to talk for maybe 40 to 45 minutes and leave time for questions. So nothing to disclose. And I like to start a little bit with the basics so we sort of understand the condition we're dealing with. So if you look at the image on the left there, that cartoon, that's about 12 weeks gestation. And, you know, it's important, we don't think about this very much about skull growth, but the skull above that area called the mendosal suture is unique in the way it grows. So you may recall the term membranous bone formation. So most of the major cranial plates form by membranous bone, and they start as little crests of cells and then develop into these plates that come together at these sutures. So what exactly are sutures? Well, they're very cellular. They're osteoblastic, so means that they build new bone. And most of the growth of the skull occurs at the sutures. So essentially they're growth plates. They're like an epiphysis in a long bone. It's where new bone is made. And what's supposed to happen during embryology is that as the growth of the bones are starting to slow down a little bit, you're supposed to have some programmed cell death under the direction of FGFR. But if it fails, you can have this successive osteoblastic activity, and that results in the synostosis. So why do we need this process at all? Well, it's because our brains come out very, very early in their development, and it's not a condition that we see in other species very often, because a lot of other species come out with their brain much closer to the adult size. But as we see here in that first year of life, we have this explosive brain growth, so that 80% of growth is complete by a year, somewhere north of 90% by 2 years, and then it all slows down. So when we think about sutures, most people think, well, the sutures fuse at about 2 years of age. That's not actually true. They don't fuse until the body stops growing, which is the end of puberty. So it's more like 16 or 18 years of age. But the functional growth of the skull sort of stops at the sutures by about 2 years of age, because that's when the brain has reached such an advanced size. And if we think about just normal skull anatomy, this Virchow's law, anyone in craniofacial surgery will tell you it's not really accurate. It's too simplistic, but it's a nice way to think about the growth of the skull, so that you could think that essentially the skull is, we think of the skull as this hard object, but it's really like a balloon, and what's inflating that balloon is the brain. So that's the air on the inside. So it's each day pushing the bones apart a little bit. We make new bone at the sutures at essentially exactly the same rate, and it's this very nice homeostatic process. So if we have things like hydrocephalus, well, what's happening there that we get splayed sutures? It's that the internal contents are just growing faster than the bone can make new bone. Eventually the bone will catch up, and that's why you get some kids with hydrocephalus that have such large skulls. So if we think about that as the basics, well, then you can sort of figure out in this cartoon the various abnormalities that will occur if sutures close. So the sort of middle bottom here, sagittal synostosis, the most common form. So if you can't grow out laterally, you get a long narrow head. Just above that, unilateral coronal. What happens? Well, if you can't grow front to back here, you become flat on that side. And because the ear is behind that suture, when that suture closes, the ear stays closer to the front of the head. Lambdoid, similarly situated in the back of the head there. And again, the ear position really is crucial, because the ear position in a synostotic process will be opposite that of a pure deformational plagiocephaly, because the ear is sort of pushed forward or back in plagiocephaly, and it's restricted in growth in synostosis. And finally, metopic is here in the bottom right, where you get that prominent pointy forehead. And this will be, I think, the only slide I have on plagiocephaly, but just to sort of show the difference here. In plagiocephaly, wherever you're flat, the ear pushes up on the same side as does the forehead, because you're dealing with normal soft infant bones that are just being displaced one direction or the other, depending on where the baby is sleeping. And obviously this became sort of an epidemic after the 1992 Back to Sleep program became real popular. And it indeed has reduced the rate of SIDS down to 50% of what it was, from 1 in 1,000 to 1 in 2,000, but it's created this sort of epidemic in our world of skull abnormalities. So craniosynostosis, just to define it, it's congenital. The abnormality should be pretty stereotypic. So if the metopic suture closes, you should see a certain shape. And if the coronal, it should be another shape, etc. Most cases are sporadic, although, as we all know, there's several syndromes out there, things like Cruzon, Apert, Sethry-Chodson, Monkey, all such sorts of different ones. And a lot of different genes have been implicated, although as we've been studying some of the bone biology here, it does look like the FGFR receptors are still a common end genetic route. It's about 1 in every 2,200 live births. And if you compare that to deformational plagiocephaly, well, that's about estimated to be 10 or 20% of babies, right? So deformational plagiocephaly, like hundreds of times more common. And the differences should be pretty evident on clinical exam. And I put that there just because, one thing I'm sort of a stickler about is I think it's, most of us should be able to diagnose these things without films. So sometimes you want imaging as an adjunct to surgery, but hopefully it's not the way you're making the diagnosis. For, I'd say, 90% or so of the cases, you should be able to figure out that diagnosis on a good clinical exam. So now getting to the treatment, if we look at it, there's sort of been a cycle of synostosis surgery. So strip craniectomy for a long time was the operation of choice, because it was sort of the only thing we had. This was, as unfortunately, through the pandemic, we lost one of our real heroes in this field, Jim Goodrich. He liked to talk about the early operations for synostosis and how a lot of those were actually done not really for primary synostosis, but for secondary synostosis, or kids who had, brain injury and the skull not growing as a result. So that took synostosis surgery offline for about 50 years as it got really derailed after people were operating for the wrong indications. And then strip craniectomy started to come back again in about the 50s and 60s. And the problem with them was that about a third of the kids would fuse back before there was any major shape changes. So the results weren't terrific. On top of that, some of the new craniofacial technologies came out, and that's when we saw Tessier and the group from France start to do these major cranial vault reconstructions. So that worked really well, but it also wasn't perfect, right? And we'll go through some of this. There's a high regression rates. They're big operations, so it's pretty tough on the kids. So as a result, we had, again, saw suboptimal results, and we saw new technologies, and that's when David Jimenez and Constance Speroni came out with the endoscopic operation. So they really are the ones to be credited with all this, and I just sort of saw that there was benefit to it, and we started doing those operations as well. So is it really a cycle? I mean, I would say that in this day and age, it shouldn't be a cycle. It's, in modern craniofacial centers, they should be able to evaluate a baby with synostosis, or maybe not a baby anymore, have a multidisciplinary team, and then decide, well, minimally invasive may be appropriate here, whereas open is necessary here. We'll go through, I'll sum it up at the end, like how I make that choice. But I would say, at our institution, we're probably now doing about 55% endoscopic and 45% open. That's just the referral pattern, but you have to be able to do both. And yet, the minimally invasive operations seem to have had a very slow adoption. And if I look at that and I question why have we been slow to adopt this, I thought one interesting place to look is laparoscopic cholecystectomy. right? So this came out in the late 80s into 1990 by a team in France, and it met a lot of skepticism, right? And yet these days, if any of us needed our gallbladder out, there's no doubt we'd prefer it being done laparoscopically as opposed to an open operation. And I know it's not exactly the same, right? Because in a laparoscopic cholecystectomy, you're taking out the gallbladder, and an open cholecystectomy, you're taking out the gallbladder. So when we look at what we're doing in synostosis operations, it's different. But some of the early literature was really pretty funny. So here it is, laparoscopic cholecystectomy, passing fancy or legitimate treatment option. And another article, let us control the virus. I guess that takes on a new meaning right now, but laparoscopic cholecystectomy, let us control the virus. Laparoscopic cholecystectomy, fantastic, question mark. And then within a year, those other articles, laparoscopic cholecystectomy, evolution, not revolution. So people were trying to see that, maybe this isn't so bad. And then threat or opportunity. And in this article, they said, hey, laparoscopic cholecystectomy, it's here to stay, and you just have to figure out how to use it. And one thing they made clear is that you probably need a lot of experience in open cholecystectomy before you can do it. And I think this is a lesson we learn in craniofacial surgery, right? You don't want your first treatment of synostosis necessarily to be endoscopic. You want to sort of understand the condition, probably have done open operations, and figure out where it fits into your paradigm. And this parameters of care document that I was quite involved with and came out in 2012. It came out just with that, right? That you want an experienced team, and you want the team to be able to make the appropriate treatment option, and that endoscopy should be one of those options. So I look at it now as a philosophically sort of different operation from the prior strip craniectomy. So I look at the open operation as a mechanical operation. I'm going to take off bones, put them where I want them, and secure them in place. And I'm going to do that in my institution with a craniofacial surgeon. And the endoscopic operations are really release procedures where we're opening the bones, we're relying on that brain growth, sort of that air inflating the balloon. So it has to be done early. I don't really do these past 3 or 4 months. You have to use some sort of device to direct growth. Well, I guess you don't have to, but it's much more successful. So those could be helmets, springs, distractors. And I say conceptually, it's like turning synostosis into a deformational problem, right? So how did the operation develop? Well, people got very comfortable using helmets for plagiocephaly and said, hey, maybe we can use these for synostosis. So if I have a child that comes to me now with sagittal synostosis, here just a common deformity, very much like what I operated on earlier today. Well, these are sort of the options I think are available to me. So whatever I do, I want to go to this, bottom right? I want to take a long, narrow head and normalize the shape and be sure we maintain volume, but I could do it as A demonstrates here with these 2 little incisions and a strip. And this is a case where I would use a helmet. B would be the same operation with the insertion of springs, and then the springs are pushing the bones apart, so you don't need the helmet, but you need to take out the springs. C would be an open operation of various forms. So these are, a lot of the removal of the bone and barrel staving people do. D are distractors. I never use distractors on sagittal synostosis, but many people do. So you put them in and they come out the skin, and the family cranks them open a little bit each day. And then E is just a variant on, and there's literally dozens of these described of different open operations. So it's just, different ways to skin a cat, so to speak. It's not like one is wrong, one is right. There's just different ways of doing it. And similarly for metopic synostosis, well, I could take a child with metopic and make a little incision and open the bone and use a helmet. Or for coronal synostosis, I could do the same. Or for either one of them, I could do an open operation. And this is, what I'm doing tomorrow is open cranial vault reconstruction for UCS. And they're both really good operations. Why do I choose one over another? It's often just when the patient presents to us. I just I have about like a 2-minute video here to take us through endoscopic operations for sagittal. So this is sort of the head holder we use. Here you can see the child positioned head up, so we have good access to the top. We make the incisions primarily with this Colorado needle. And I use 2 incisions. Some surgeons use a single incision, either longitudinally or horizontally, but pretty similar motifs to the operation. So we'll drill a hole. This is working at the back. Just expand it with a curette, then expand it further with Kerrisons, and then just let that be as we go to the front and do the same. So making a burr hole, expanding it. And then once we have a little bit of that opening done, and we've gone all the way to the anterior fontanelle in the front and back to the lambdoids in the back, then we bring in the scope. And we use the scope really just to get a good separation of the planes here. So here's going to the scope view. So there you can see the sinus sort of coming up into a little area in the bone. You can see the nice prow internally, and some kids have the ridge internally, some have them externally, sometimes it's both. It's a little hard to predict. So we're looking there, you can see the other opening up in the front. And that's just separating outside the bone, between the bone and the periosteum. Just looking again on the inside, and that's from the other burr hole, someone's just pushing on it. And then once it's separated, then we just use heavy bone cutting scissors to complete the strip. So in my practice, I do a relatively narrow strip of about 2 centimeters. I know some people like to do 6-centimeter strips. I think a couple of centers now, St. Louis, here's the removal of the strip. St. Louis and the DC and Baltimore groups have shown essentially equivalent results doing narrow or wide strips. Put in some gel foam and then irrigate and close it up. So it's, you know, compared to a reconstruction, it's a pretty small operation. But I will hopefully convince you it's an effective operation. You just have to know how to pick the patient. So why have we been slow to adopt it? So I like this slide because it's taken directly from a craniofacial surgeon's website who's trying to talk against endoscopic surgery. They haven't updated the website in over a decade, but these are the points, and we'll sort of go through them one by one and say, well, maybe it's not so. So I won't go through them here, but on the next several slides, we'll go through each of these points. So one point is that correction is not achieved at surgery, so infants must wear a headband up to a year afterwards. And I'd say, yeah, in my practice, this is mostly true. Other surgeons are using things like distractors or springs, but this one I would agree with, right? I think they do need to wear a helmet. But I guess my counter would be, well, should we make that choice or leave it up to patients and their families? Because there's lots of kids out there in helmets these days, and mostly for very benign reasons. So if a helmet's going to let them have a much smaller operation, is that not a good choice? You know, I think that's up to a family to decide. Do headbands function similar to synostosis? I mean, to me, this, you know, some of this is just, it's almost not worth talking about, but a properly designed helmet, it's a shield, right? It's not a vise. It's not squeezing in prominent areas. It's just shielding where you want the growth. And I think we all use them, right? So it's if we really thought they were functioning like synostosis, maybe we shouldn't be using them on anybody. I particularly like helmets over springs or distractors because springs and distractors only work in 2 dimensions. They're, you know, it's a width and length sort of device. And I think the helmets give you a nice contour in 3 dimensions. Like if you think the top of the head's getting a little flat, you can add a little curvature to it. And you can't do that with the spring or distractor. So I like the ability to adjust it over time. There's pretty good data that helmets do not restrict growth. And again, if you're going to make this argument, would you stop using the helmets for plagiocephaly because you're concerned about their effect on the brain? And I've never heard anyone make that argument, that they wouldn't use a helmet for deformational plagiocephaly because they're concerned about it affecting brain growth. So we use them all the time. And this top one here is for bilateral coronal. This is bottom left is metopic, and bottom right is sagittal. So each condition has its own sort of helmet style to allow for the growth. So are they not as effective? And I think that's sort of a legitimate question to ask. Maybe the first legitimate question in that list of questions. So I think there's a lot of data that they are effective. So this is the article we put out last year looking at the first 500 consecutive patients from our series, and we're now at about 750. But this is when we hit 500, and we analyzed it for 2 years to have follow-up data. So 500 patients, sort of typical distributions, more than 2-to-1 male. Average age at surgery was 3 months. Average weight is 5.9, and we very specifically wait till 5 kilos because we think it's a lot safer and lower risk of transfusion. The operative time about 47 minutes, anesthesia time, so a little over 2 hours. Blood loss, that's 13 mLs per kilogram, and hospital stays essentially 1 day for everybody except for syndromic kids, or sometimes a little longer. 16 were admitted to the ICU. These were all the syndromic kids. Very high helmet compliance, and this is now about 2 years old, but it's about now 7 years of follow-up. And this is the distribution. As you'd expect, 50% of the kids had sagittal synostosis, then almost equal numbers metopic and unilateral coronal. And then in our series, we had about 7% were syndromic, and I'll call these out a little differently because the implications for syndrome are a little bit different. If we look at the entire series, the 6.6% had blood transfusions, and you sort of know most of the time intraoperatively if they need one. Complications, there were 7 that required a surgical repair. These are not, I'm not talking about reoperations here. These are the surgical complications. So seven patients had complications. So 4 wound infections that required debridement. I think the helmet does irritate the incision a little bit, so you have to be cautious about helmet design. 2 skull defects and 1 CSF leak. Head growth tracks very normally over time, and we get this on everybody. You see, we had over 95% ability to look at head growth over years, and nice statistical changes over time. And then the syndromic patients, a little bit different, right? And you definitely, if you're going to start doing endoscopic surgery, you don't want to be starting with the syndromic patients. These are a different group that requires a little bit more skill and just knowledge on how to follow them. So much higher risk of blood transfusion, and this easy reason for that is it's usually more than 1 suture. So each suture loses a certain amount of blood. Increased length of stay, so getting much closer to 2 days than 1 day, and about a third of them needed a second operation. So why, you might say, well, why do it? Well, I'll try and go over that a little bit. Why do it? How were the results? This is a smattering of articles from us and from others. We've shown that the results for sagittal are really quite comparable. Similar articles out of St. Louis have shown the same. I mean, I think there's a lot of data to support good clinical results in sagittal. Coronal, this is sort of that classic deformity, ear advanced, brow back, nasal deviation. And here are some of the classic findings. Again, really good data now from lots of centers showing good results with endoscopic. So here you can see a pre-op, and these are all laser scans used for the helmet pre-op. This is during helmet treatment, and this is at the end. And what you don't really see here, and in the limitations of this talk, but how much better the orbital and nasal results are in the endoscopic group compared to the open. And that's been pretty well documented by us, and even CHOP has talked about the decreased need for eye muscle surgery if you have the endoscopic operations. Metopic, one thing to be careful about with metopic is it's a very varied phenotype, right? So we are pretty careful about using the criteria Seattle's described nicely for which patient should have surgery. So usually if this interfrontal angle is less than 118, you could be considered a candidate for surgery. And that's what we use it for, right? So we don't use it on metopic ridges. I think, these things should not be operated on. A lot of babies will have a ridge and it dissipates by 3 or 4 years of age as the surrounding bones thicken. So we never operate on these kids. But when we have kids like this, we do operate, right? So if the interfrontal angle is severe, they probably are going to benefit both cosmetically and maybe from brain growth with an operation. And here you can see this is just, again, just a laser scan from our group, and this is a reference from the St. Louis group about the results. And this was a really nice article that came out last year in Pediatrics, looking at the metopic group. And then lambdoid, it's a much rarer situation. So, if you're seeing more than one lambdoid a year, you have to wonder if you're operating on things that aren't true lambdoid. But some of the classic features are that mastoid being displaced inferiorly and that whole windswept appearance over towards the opposite side. And we came out with this article last year looking at our open versus endoscopic for lambdoid, and they're not big numbers, right? Because even at our center where we see nearly 100 kids a year, we see about 1 or 2 lambdoids a year, but it was very comparable results. And then bilateral coronal, again, multiple places now have shown pretty good results. You could just see on the right side of the screen here that sort of classic widening in the front that corrects when you open the sutures. And here's an example of a bilateral coronal, a child with APERT. And I would sort of suggest that I've done a lot of APERT kids open, that it's hard to get such good results with an open repair of APERT. This is really a normalized skull shape. So what is the big problem with APERT? It's like these kids, they grow high, they develop this significant craniocephaly, and a lot of places now are doing posterior releases early on. So even though the sutures are open, they move out the back to try and avoid the upward growth, that craniocephaly. So that's a 3-operation paradigm. They open it up, they put in distractors, they take out the distractors, and then they go back and do the frontal orbital advancement. So if you say, well, why, if I have a 1 in 3 reoperation rate, why do it? So I'd say, well, 1 in 3 of my kids with bilateral coronal need a second operation, as opposed to all of them needing 3 operations in the other treatment paradigm. So I do think it's warranted, and you have to explain to the family that there's a chance that they're going to need more surgery, but it will correct the craniocephaly. Even in the kids that need more surgery, it corrects the craniocephaly. So I'd say the verdict is that, in my view, the outcomes are really comparable. You have to know how to use which operation, when should it be open, when should it be endoscopic, but you should have pretty comparable outcomes. The risk of a second operation to rebuild holes in the skull, this is coming back from that surgeon's website. Not at all true. In fact, the group from CHOP showed here that, if any operation done past about 9 months of age has a significant risk of leaving skull defects if you don't fill it in. Our group showed something similar, and I would say it's a rare issue. We've only had 2 patients in the series that needed skull defects filled in. So I'd say it's actually much lower than in the open operations, because you're doing the operation much earlier. Are the operations dangerous? This is something people still contend that, well, if you do it endoscopically, you don't have adequate view. And I think this is just, it couldn't be more clear that these operations are safer for the kids. I did 2 of them today. I was out of the operating room by noon, and they'll both go home tomorrow. Tomorrow I'm going to do an open case. The one case will go till 2 or 3 in the afternoon, and they'll be here to the into the weekend with a night in the ICU. So it's definitely, I have no doubt, if I had a child or grandchild with this, I'd want to have the endoscopic operation from a safety perspective. And then what about reoperations? And I think here you really want to look objectively at both open and endoscopic. So, you know, reoperations for ICP or cosmetic issues, it was 3.6% of our 500 patients, and almost all of those were in the syndromic group. And the average time to reoperation was 1.9 years. So we extrapolated that. We expect reoperation rates of about 4.2% of all patients. And if you exclude the syndromic, it's much closer to 1%. But this is not just, you know, we have to be intellectually honest with ourselves, because you could say, oh, look, endoscopic needs reoperation. Well, it probably needs reoperation less than the open operation. So here's some good studies. This is a 16-year follow-up from Children's National Medical Center. 5.4% of the kids needed reoperation, and 31% children with bilateral coronal, right? So I said 1 in 3. Well, they're saying the same thing for the open operations. This is an analysis from our group looking at reoperations in syndromic kids. Very high reoperation rates if you want to get it cosmetically really perfect. And quite honestly, not even perfect. You know, you don't, the APR kids don't end up perfect. CHOP did a couple of really nice articles looking at the long-term follow-up, and there was a clear trend towards worsening aesthetic outcome over time. So a place like CHOP, which I think is an excellent center and really innovative, they still had 38% Whitaker classes 3 or 4, and 4 was needed a reoperation, and 3 was unhappy with the result. So it, you know, even in really good centers, if you follow these kids long enough, what you're going to see is regression. How about for ICP issues? So operating for ICP issues. So this nice look from Pittsburgh, about 1.5% of their just simple sagittal kids needed reoperation for ICP issues. This study from Nate Sullivan's group showed 6% of their kids with non-syndromic single suture synostosis needed reoperation because of papilledema. And it can happen in endoscopic surgery too, right? So this is what I'd consider a successful case where it stayed open. This is another APR child, so it stayed open. They had good correction, did not need another operation. But here's a child with Seth Ray Chotzen, or this is how it started. I did a bilateral coronal release, and that did pretty well. But then over time, they all closed, right? So the metopic, sagittal, and both coronals closed off, and that child needed another operation. So how do we know? Like here's a head growth curve on a successful child, right? The first child. So the head growth jumps up and stays up, and this is the one that needed another operation. The head growth drops off, right? And I would implore everyone to get, you know, regular head circumference measurements. I do it for at least 5 or 6 years. Pediatricians stop at 2 years. So if you ask pediatricians to do it, they don't, it's in their practice, they only get head circumference till 2 years of age. And here's just showing the those changes. And this is a child that refused after open surgery, right? So what do you see? Well, they were up around the 75th percentile, came down to the 50th, 25th, and then the 3rd percentile. This is a child had an open repair and refused. So you got to watch this on all of your kids. How long do you need to follow kids for that? Well, you have to understand how long the brain is growing for, right? So if you look at brain weight over time, what you see is that the brain essentially reaches its adult weight by 3 years of age, right around 36 to 38 months. If you look at this nice study that used MRI, they showed 90% of brain growth complete by 2 years and well higher than 95% by 6 years. So putting this together, I mean, how long should you follow your synostosis kids? I mean, you should never stop following them at a year of age, as I have seen done. So you always want to follow them to about 5 or 6 years of age, because if you follow them till then, you're almost never going to risk a kid who gets delayed intracranial pressure. So most kids that are going to need a reoperation, it's within 2 years of surgery, and I'd say all kids should be followed until 6 years. And how do we follow them? Well, we do clinical exams. You know, for the endoscopic kids, I do a 4-week post-op, then every 3 months till a year, and then at least once a year until they're 6. and we do head circumference measurements. We have a neuropsychologist as part of our program. And for the syndromic patients, we get serial eye exams, and for the non-syndromic, we don't always get the eye exams serially, but we get them all by the, when they're about 4 or 5 years of age to look for papilledema. That's when papilledema becomes reliable. And imaging is just as needed. We don't routinely do the imaging. We do it if we have a concern. A couple of advantages to minimally invasive. For any of you who've done an open surgery, you'll see the bone sort of fuse back. You don't see good definition of the sutures. One thing that can happen in endoscopic surgery is it's almost like you reset the clock. So this is the same patient here, right? They had left coronal. Well, what happened? We opened it endoscopically, and at a year of age, you look at it, it's like they never had synostosis, right? The nose straightened, the eyes are relatively level, and they have what looks like a normal suture. And what I would say is the kids that do this, that form these neosutures, they grow normally over time. They just get better and better, which is different from what we see in the kids who've had CVRs, where you can make them perfect or even hyper-correct at surgery, but you can't beat the biology. Eventually, they start to lag and regress, as the CHOP group showed very nicely. So this is an article from our place, and this is one from St. Louis looking at the sagittal, right? So here they did an endoscopic release of the sagittal, and then this kid just formed a new sagittal suture, right? So you could expect relatively normal growth from a relatively normal suture. Here's an APER child with these neosutures forming, right? So instead of fusing, they form a new suture. And I'm just, for any of you who have done lots of craniofacial surgery, I think you'd be hard pressed to get a result as good as this one on the right in an open operation. It's very hard to correct that terucephaly. So how about the cost value? I think it's, we don't want to make our decisions based on cost, but it's big. It's a big issue these days. So we did a big study looking at sagittal kids, and this was very comprehensive. We looked at missed hours from work to come to the appointments for helmets and the like. We factored in, the depreciation of the car for the miles driven, et cetera. With all of that, it was still far cheaper to treat someone endoscopically, 40% of the cost. 3 other centers have shown almost exactly the same results. It's always about 40% of the cost of the open operation. And this is the entire treatment paradigm, not just the surgery. You're talking throwing in the helmets and everything. And as we look at sort of value, and this is defined at a very nice course here at Harvard Business School, is value as an outcome that is meaningful to the patient over cost. If the cost is much less and they like the outcome at least as much, then it's a far more valuable operation. And I think I can, I know the cost is less. I wouldn't do these operations if I didn't think that we were doing somehow benefiting the patient from an outcome perspective. So I think from the value perspective, this is something we're going to have to look at quite a bit going forward. So I'd say both operations are safe, they're both effective. And how do you make that decision? So just wrap it up here. So when I have a child come in, if they're up to 3 to 4 months of age, I'll consider endoscopic. If they're, getting 5, 6 months of age, and certainly beyond 6 months, then we don't even talk to the family about endoscopic surgery. We just say that, we may or may not recommend treatment, but it will be an open operation. Severity, I would say by and large, I don't factor in severity, except that if a child really has a multiple suture synostosis, and we've all sort of seen these cloverleaf type things where the bone is jutting into the dura, I think those are extremely difficult to separate out, and you're going to have complications endoscopically, and that's where you really want an open operation. We could do the endoscopic operations, quite frankly, because they're easy, right? The suture does not, at a fused suture, the dura doesn't stick to the bone, so you can separate it off easily and do these operations. Open, you can obviously do at any age. Reoperations, well, endoscopic operations, you do them once at 3 and 4 months of age, and if it didn't work, reoperation is not an option. So clearly, anyone that needs a reoperation, it's open operation. And family preference to me is the most important thing. I always discuss both types of surgery with each family and give them the choice. So conclusion, at this point, There's well over 20 years of literature on this from Jimenez's group. I've been doing these now. We're in the 17th year of doing endoscopic surgery. And I'd say it's very safe, it's very effective, and it's reliable. I'd say any of the theoretical concerns about the disadvantage are really just not borne out by long-term experience. The outcomes are definitely on par with open surgery if you're selecting the patients right, and it's definitely a better value as well. So I would suggest to anybody in the audience that both open and endoscopic techniques should be embraced, right? It's like, we shouldn't be saying we're only going to do it this way or only going to be doing it this way, because there are times when you want to do one and times you want to do another. And I think they should be embraced and standard part of the treatment algorithm at comprehensive centers. And then these are our references on endoscopic surgery. So, we've published about 25 articles on it. And that's it. Happy to take questions.
Well, thank you so much, Dr. Proctor, for that overview for us. So one of the questions I had for you that we struggle with here in our practice is who does your helmeting for you? Is that an outside center? Do you have somebody in-house? And then how do you educate the helmeting centers to kind of mold the helmets the way that you need them to be molded?
Yeah, so I would say for sure that if you're going to do endoscopic surgery, it's actually going to be more labor intensive for you, right? The follow-up with the patients is more intensive, and you need close communication with your orthotists. We have a very good orthotist group here in the hospital. So if the patient is local, we use them. But I will stress that we don't ask patients to come here if it's not convenient for them. So we, I won't talk about names of companies because I don't want to. I have no affiliations with these, and I don't want to do any disclosures. But but there are some good national brands that are all around the company, and most of these helmets are made in the central location. Right? It's not like each shop is making their own helmet. So they'll have a pretty good understanding of how helmets work. But I think that, anyone working with a helmet understands how the helmets work for plagiocephaly. And it's not philosophically that different for synostosis. You just need to understand where you want the pressure and where you want the shielding. So if you have someone who is good with a helmet for plagiocephaly, and if you talk them through the concepts of what you're trying to achieve, it really should be pretty effective. So the ones I'm doing, I did 2 of these operations today. One of them is from Western New York, so it's about 7 hours from here, and they're going to have a helmet person in their hometown do it. And the other's from Connecticut, and they're also going to have someone in their hometown do it. Both happen to be orthotists that I've worked with many times before, just because of the referral pattern here. But I will still be seeing those patients back, in 4 weeks to be sure that we're getting off on good footing.
Okay.
But I think with education, it really can work quite well. And I know there are centers that say you have to come back here for your helmet, and we don't do that.
Okay. Well, one of the questions from the audience is, have you seen problems with compliance with helmeted patients? Well, you've already gone through this, and has there been a need for repeat surgeries due to lack of compliances? So I think your talk covered that sufficiently. The next question is, many thanks for an excellent presentation. I find metopic one of the hardest to treat endoscopically. The first question is, what is the transfusion rate you have for your metopics endoscopically? Any tips to reducing this rate in metopics, such as progressive or staged bone removal? The second question is, what is the width of the craniectomy for metopics? And third is, getting low down to the nasofrontal suture is sometimes difficult. Do you use the drill under endoscopic vision to go this low?
Yeah, so I happen to have a set of skulls next to my desk here. So, so I whoever asked the question, I agree. I think metopic is my least favorite suture to do, and it was the one I did last. you know, when I started doing this, about a couple of years into doing these, I did Metopic, and it was actually the daughter of an orthopedic surgeon at the hospital, and they insisted I do it endoscopically. And you know, it's about, must be 13 or 14 years ago now, and I still see them at the ice cream shop, and she's very cute. But I would say a couple of things on Metopic. One is, for comparability of results, I think Metopic's the toughest one to get as close to what you're going to get as an open, right? For sagittal, I think I can, by and large, do better than I'm going to do with the open operation. For Metopic, it's hard to get that bone to come all the way out. I mean, I think we have, you know, and I tell families that. I say if the gold standard is an open operation and I gave that a score of 100, I'd give the endoscopic a 90. You know, it just doesn't get out quite as far. And it also is technically the hardest because this bone is very thick, and you don't want to do an incision down here on your brow, right? So you're working from above where it gets pretty thick. So I'd say I usually do my incision at the hairline. Going back is pretty easy. That bone tends to thin out quite a bit, and you can go superiorly quite easily. Going inferiorly, it gets thicker and thicker. And I've become a big fan of ultrasonic devices to dissolve it. I happen to use the Sonopets because of what we have. I did a Metopic today. I think you can effectively get all the way down, and I don't stop until I'm at the nasal frontal junction, and I can physically separate the bones with like a snap where I just push it apart and I can see the gap developing down here. So I tend to use something like the Sonopet, but there's other bone scalpel devices that can do it. I don't stage it. I don't go very wide as I get low. I think if you think like, where do you want the growth in this operation? You don't actually want growth at the Metopic, right? You know, if you're, put that down for a second. If you're starting triangular, you actually want the growth at the coronals, right? You're trying to flatten the bones out. So turn that triangle into something closer to a straight line. So I think of it as more of an unlocking procedure, unlike sagittal, where I really want to get a good couple of centimeter gap. Here, I'm unlocking the bones and getting them into the helmet quickly to work on it. Transfusion rates, I think they're pretty low in my hands. You know, certainly less than 5%, but it's you know, I've done a lot of them. I tend to, you know, as I work, I will feed like gel foam or cottonoid under the bone to tampen out any of the little emissary vessels. I'm quick to, if I see an emissary vessel, to use the bipolar on it. But it's not, if you're just starting an endoscopic practice, you don't want to start with Metopic. You want to get some experience beforehand. Those are tougher.
And do you use the claw for the Sonopet to get down there? Is that the one that you use?
Yeah, I think, you know, there may be different tips. Sure. Here it's called the Spetzler micro claw. And there's either the long or standard. Either one works fine.
Perfect. Great.
So hopefully the audience members will ask some additional questions. The ones so far have been great. I'll ask another question while we're waiting on them. You touched a little bit on the question of ICP, and I know some of your thoughts, but I think that would be helpful for the audience. Sort of, what do you tell families about the risk of ICP with craniosynostosis? Obviously, syndromic is different than non-syndromic, but in the non-syndromic patients, what are you sort of telling to the families about development and cognitive aspects and ICP? I know we've discussed some of these studies and your thoughts.
Yeah, so I'm going to make the assumption that you mean if untreated synostosis.
Exactly, sorry.
Yeah. So I think the reality is we are sort of at the, no pun intended, infancy of this, the whole neurocognitive area, right, on synostosis. I mean, we know that if you look at large cohorts of kids with synostosis and without, that the ones with synostosis perform just a little bit worse. You know, like if you look at IQ testing, and IQ testing standardizes to 100, so the standard population is 100. Kids with synostosis are between 98 to 99 on average. And you just see all sorts of things across the literature about what is the rate of ICP or cognitive issues. And, you know, the one really fun study, not fun, I mean, I think the result is fun, but Seattle looked at a big group of kids with metopic synostosis, and they looked at like 8 different factors, and the only one that correlated to neurocognitive outcome was level of parental education. You know, it didn't matter this treatment type, age of treatment, whether or not it was treated. If you had, you know, if it was a family that sort of valued education, the kids tended to be smarter, and if they didn't value education, they were less smart. And you know, I think lots of us can relate to that. You know, that it's your environment has a lot to do with it. So I usually will quote families, you know, the risk of untreated single suture synostosis to be about 5 or 10%, that there would have been a brain growth issue that we could have prevented with the operation. Now, what do I mean by that? It's like, you know, all of these things I believe are genetically driven. We don't always know the gene, right? We know it for most of the syndromic conditions. We know it for some sagittal kids, but I think all of these are, you know, as we get more sophisticated, we're going to find there's a genetic predisposition for them. And some of those genes also affect basic brain growth, right? So it's, you know, what we don't want to do is tell a family, well, if you treat this, your child won't have any problems, they'll be perfect. And if we don't treat it, they're going to be in terrible shape. They're probably going to do a little bit better with treatment on average. But some kids are going to have issues even with surgery, and some kids would never have an issue if you never operated. So it's pretty hard to know. So what do I tell a family? You know, let's say I have a 2-month-old come in with sagittal synostosis. I said, well, the reason you're here is because your child's head looked different, right? That's the reason you're here in a 2-month-old. It's not because there was any developmental issues. We know with surgery that we can correct that, right? So we know if we do the operation that the cosmetic issues should normalize. They're not going to be appearing different from their peers. And we also know historically in populations not treated that they were detectable to their peers, right? There was a good study decades ago looking at untreated sagittal in kindergarten, and the peers all knew the child that had the sagittal synostosis. So we know we can correct that, and we believe we will mitigate against any brain growth issues if you open the bone. But I would say you never want to scare the family to say, well, if you don't do this, your child's definitely going to have a problem, because we don't know that's the case at all. Does that answer it?
Yeah. And then another question while we're waiting for the audience to think of some more questions. You talked a little bit about not being a big proponent of imaging, and I know your thoughts on radiation risk in kids, but maybe you could share with the audience sort of your views, how you do the toggling in terms of the exam, and then also what population of patients you might consider an imaging study in.
Yeah, you know, and just for context, like today I did a 2-month-old with sagittal and a 3-month-old with metopic, and we didn't have imaging on either of them, right? They were very classic. You know, what do you see? Well, the ridging is going to be there. There's just certain things about the morphology, right? You can have you know, and I can give a whole lecture about just unusual head shapes that are not synostosis, but you can clearly have elongated narrow heads in normal populations, right? You can have that Mendosal suture stay patent. You can get Laparoscopic, just a prominent occiput. If they're premature and they spend a lot of time lying on their sides, or just not premature and spend a lot of time. You know, there's a lot of different ways the head could look funny, but I think if you see them in person and you see them early, you're almost always going to be able to move the bones. Like that's what you were saying, toggling. And I don't stop an endoscopic operation until I know that the bones move independently, right? That's what your goal is. So I do think feeling for the ridging, being able to move the bones physically, the only exception really being the lambdoids. I mean, those are always going to be stiff, but you're going to know a lambda, you know, by and large, a lambdoid from a non-lambdoid. And there's just, you know, especially as you look at the asymmetric conditions, the position of the ear relative to the rest of the deformity really should give it away. So I think if you're, where does synostosis live in the whole like gamut of pediatric neurosurgery? It's like, well, we think if we could do tumors and moya and all that other stuff, then synostosis is just, we take off pieces of skull bone all the time. And I think, quite honestly, that's also the reason we've fallen well behind craniofacial surgery, right? Because they study this and they understand it better than we do. And it's relatively rare that you have someone that in neurosurgery who focuses quite a bit on synostosis. So I think if we're going to do it, we really want to understand it and know how to diagnose this and know what the treatment options are, in a more sophisticated way than we sometimes deal with it.
So we'll wrap it up with this last question. So one of the things that always comes up is that you'll have a preemie baby who is born 10 weeks early and is found to have craniosynostosis. And the question always comes up is, where do you cut off that 3-month mark, that 4-month mark for those kids? And do you give them a little bit more leeway because they're born premature or not? And so I'd love to hear your thoughts about that.
Yeah, that's a good question. I'd say the 3 months in my mind is from a full gestational age. And I probably depend more on weight than I do on age. So I would consider like the ideal time to operate being closer to 10 weeks, right? Because I do find that the 5 kilo mark is a really good cutoff. If you're under 5 kilos, you're more likely to need a blood transfusion. And it's just a little bit, everything about it's a little tougher, starting the IVs, the NPO period, et cetera. So we really try and hit 5 kilos. Today, both of the kids were the same weight. One was 7 weeks and one was 13 weeks. And so if they've hit 5 kilos, I'm pretty prone to go forward regardless of age. So if I had a child born at 30 weeks, by the time they hit 3 months, essentially they're 2 weeks after their full gestational age. I usually sort of split the difference,
Okay.
I don't necessarily wait till they're, another 3 months, unless they're very small.
Okay.
Whenever they sort of seem to be getting up to that 5 kilo mark.
Well, thank you. That was an excellent overview. Thank you for giving us your time tonight. And we look forward to seeing what else your group comes out with the results in the future. We'll be looking forward to doing our next Zoomposium here next month, where we'll be focusing on spine. So we look forward to having everybody join us then. Again, thank you, Dr. Proctor. We really appreciate you joining us tonight.
And our next session will be on March 8th for those who want to tune then we'll send out a flyer closer to then with our speakers. Thank you again for speaking today. Wonderful talk.
Yeah, it was a pleasure. Thanks for inviting me.
Okay. Thank you.